Good morning, and it's a great pleasure to be in Delhi at this time. I went to school and did my MBBS and post-graduation in Delhi at Guru Nanak, and I have loads of friends here. So it's always nice to come back and be given the opportunity to speak. What I'm going to talk to you about is, in fact, we changed the topic to fit into the actual instructional course, and I'm going to talk about the changing indications for refractive surgery. Refractive surgery has evolved over the last 20 years, and we no longer have just excimer laser refractive surgery, but there's a whole range of other procedures that have come online. And at every age and at every prescription, a patient has different requirements, and what I'm going to share with you is my approach to looking at these individual patients. These are my financial commitments or financial interests. What we're going to think about in terms of refractive surgery, it's actually vision correction surgery in a way, and it's a surgical correction of refractive errors or focusing errors. The aim and the objective for the patient is to see better without glasses or contact lenses. And the reason a patient is wanting this type of surgery is to improve their quality of life. They feel if they see better without glasses, they live better, and there is no doubt that there is significant evidence to show that improving spectacle-free vision, unaided vision, makes a big difference to the quality of life. We're all ophthalmic surgeons, we're all refractive surgeons, but we have to always keep in mind that apart from refractive surgery, there are two time-tested options to correct focusing errors. And both of these have their own pros and cons, but spectacles and contact lenses are something that we need to always consider when we talk to patients in terms of refractive surgery. This is what the patient says: I want to see clearly without glasses. That's the reason the patient is sitting in front of you. And these are the options we generally have. For laser surgery, we have LASIK, PRK, whatever you want to call it. SMILE is something that's come on recently. You have phakic intraocular lenses, lens exchange surgery, refractive lens exchange, and refractive cataract surgery. All these are refractive procedures which we all have to be comfortable with in carrying out. And then we have bioptics for special cases where you combine two different procedures to achieve the actual refractive correction. A simple way of classifying these options is to say, okay, there are two optical elements in the eye, the cornea and the lens. The lens is the variable focus zoom lens. So if the lens is normal, you would treat the refractive error on the cornea, and this is what you would do in pre-presbyopic patients. The moment a lens shows changes of presbyopia, in other words, there is deterioration in the optical quality of the lens and the zoom function of the lens, and the patient goes presbyopic, you would start thinking of wanting to correct the refractive error in the lens plane in the presbyopic patient. So let's begin first by looking at the pre-presbyopic options. Excimer laser surgery is where we go, and there are pros and cons of LASIK and LASIK, depending, and the variation really is in the early postoperative phase and the speed of recovery. The visual results in the normal range of refractive errors at 1 year shows no difference between these techniques. We are all familiar with the factors we have to keep in mind when we think of excimer laser surgery. We've already heard about keratoconus, anterior basement membrane dystrophy, dysfunctional tear syndrome, rosacea, ectasia, connective tissue disorders. All these are factors which make you wary of excimer laser surgery. And then you have individual anatomical parameters like the corneal pachymetry, residual stromal thickness, and the pupil size. So all these factors are very relevant to a choice of excimer laser surgery. So what are the results? These are the generic results from a meta-analysis of various results. +3 to -6 diopters. This is the low to moderate prescriptions, which is where the majority of patients are. 99% of patients achieve the driving vision or better without spectacles. There is a 1% enhancement rate in this particular age group, and there is a less than 1% risk of losing significant best corrected visual acuity. So these really are fantastic results, and this is the group where excimer laser surgery really comes into its own. What happens in the moderate to high prescription of -6 to -8, for example? Well, the results are still pretty good, but now the numbers are down to 95 to 97% driving vision or better without glasses. The enhancement rate goes up to about 3 to 4%. However, the loss of best corrected vision or the risk of ending up worse is still very low at less than 1%. It's when you go beyond the -8 or you go beyond +3 that the results really start dropping, and you get relatively poor results both for efficacy as well as enhancement rate, and the risk of losing vision or ending up worse than what you were goes up to 5%. And it's for these kind of patients that we then start looking at other options in the pre-presbyopic age group, which is a phakic intraocular lens. And in this, you have to consider the issues of acute glaucoma, cataract, sizing issues is a particular thing, and then you have to keep in mind you need an antechamber depth of 2.8 millimeters and an age group of less than 40 years to really carry this out. So what about the presbyopic options that we have? These are options you would consider in a presbyopic group. And there really is one single option, which is you change the lens, you do lens exchange surgery. We've been doing lens exchange surgery for 3,000 years, so it's high time humanity got good at it. And as the surgery efficacy and safety has got better, we are removing the lenses earlier and earlier. Now that we have small incision phaco and refractive cataract surgery, we are happy to intervene with symptoms of just glare and dazzle, although the patient might still be 6'6". So it's natural that as things get better, we get better lens options, we would start thinking of intervening when a patient gets presbyopia. It's just a natural progression of the whole thing. And we're already seeing this in the various types of cataract surgery. This is what I call standard phaco, where you use a lens, you improve the clarity and the symptoms of glare. The outcome measure you're interested here is best corrected visual acuity. Patients need glasses for this all the time. And then you have the two levels of refractive cataract surgery where you're wanting to improve patients' vision without spectacles, not just for distance, but also for intermediate and near. So just to recap, these are all the options we have. So how do we go picking one over the other? And this is how I tend to approach a patient. If a patient has one functional eye, this is a pre-presbyopic patient, the refraction is unstable, or they have unrealistic visual expectations, I don't do any surgery for them. I think we need to avoid these kind of patients because the risk is too bad. What about other patients who don't have this? Start with the refraction, the cornea, the ocular surface, the antechamber depth, and the risk of ocular injury in their normal lifestyle. So +3 to -8 diopters, this is the commonest group. Normal cornea, normal ocular surface, any kind of antechamber depth. If the ocular injury risk is normal, LASIK or SMILE. If the ocular injury risk is high, you would consider LASIK or SMILE. The same group, if they have issues with their cornea or the ocular surface, I would switch over to a phakic intraocular lens, irrespective of what the actual prescription is. -8 and above, irrespective of what happens to the cornea, provided the anterior chamber depth is greater than 2.9 and the patient is less than 40 years of age, I shift to a phakic IOL. This is the group where we have very few options. This is the 3 diopter and higher hyperopic pre-presbyo. Normally, most of these patients would be able to accommodate, but for some reason, if they have astigmatism, then they don't tend to accommodate. But again, here, provided the anterior chamber depth is okay, you could opt for a hyperopic phakic intraocular lens. The fact is that for lasers, any corneal issues, and for a phakic IOL, any issues with the anterior chamber depth or age, I do not offer any refractive surgery because I think the risk is too high. In a presbyopic patient, similar baseline indications, one functional eye, unrealistic expectations, no surgery. What about patients who are okay, in every other way. And here the factors we need to look at are refraction, the reading at. This indicates to you the severity of the presbyopia, the cornea, the ocular surface, and the retinal detachment risk. A hyperopic presbyope with a reading out of greater than 1 diopter, normal in every other way, is really an optimal candidate for lens exchange surgery. Refractive lens exchange, clear lens exchange, whatever you want to call it. But the fact is, these patients do very well. Low myopic patients, less than 1.5 diopters of reading out, normal cornea, normal ocular surface, I tend to offer them LASIK monovision. You give them a trial of contact lens first, and then go ahead and do it. The same patient group, if they have any corneal or ocular surface issues, I shift over to lens exchange surgery monovision. So you would only do one eye, get that eye focused for distance, and the non-dominant eye is left. -3 and above, this is the high myopic group. Reading out has to be more than 2 diopters. They have a high risk of retinal detachments. So we would consider lens exchange surgery only if the patient is willing to accept that higher risk. Emmetropic presbyopes, +1 to -1 diopter, greater than 1.5 diopters of reading out, normal, the monocular lens exchange is what we would do. The fact is, if you think of LASIK for everyone, if the only tool you have is a hammer, then you tend to see every problem as a nail, and that gets into trouble. So just to start finishing off now, is the benefit really worth the risk is what you need to assess in an individual patient for each and every procedure, and you have to be able to provide answers to these questions for your patients. What is the level of vision they can realistically expect from the surgery? Does this level of vision give them the quality of life benefit they are looking for? What is the level of individual risk, however small, they will have to take in order to achieve that level of vision? And only then can they make an informed judgment as to whether the benefit is worth the risk. You have to prepare for success with your patient. Thank you.